We're pleased to welcome Dr. Cole, who's going to be talking to us about emerging therapies in multiple myeloma.
Oh, Lordy, I'm not nearly that entertaining or that interesting, but I got cool cartoons, I think. Thanks for inviting me. I'm from Detroit. Our nurses are actually from Windsor, and they taught me how to speak Canadian. So they said, say sorry. Is that right? Okay. I'll put my Rush t-shirt back on. I was wearing it yesterday, and I thought people were going to go, yeah, Rush. And I was like, no one said anything. So maybe that's culturally insensitive. I don't know. So we're going to talk a lot about clinical trials, because that's, where the frontier and where the horizon is with myeloma really has to do with the clinical trials that are being conducted. So we're going to do a bit of level setting of how to interpret these clinical trials. Then I'm going to riff a bit off of what Joe talked about, specifically about immune therapies. So we'll talk about the antibody-drug conjugates, CAR-T, how they work, bispecifics, even the trispecifics, and then we'll talk about where all these therapies come from. So I like to talk about the iceberg model of myeloma, and Joe hit on some of this about what a partial response is, what a complete response is. And when people start out with myeloma, it's like an iceberg. They have a lot of disease. But as you start treating, it starts to disappear. And as you get deeper and deeper in the treatment, the M protein may start out at 6, it goes to 3, and that's a partial response, cut in half. Then it goes to like 0.3 of EGPR, and the deeper the response, the smaller the disease. And you want to shrink that iceberg down to an ice cube, because the smaller the ice cube is, the longer it will take to grow back. But even deeper than those blood tests is MRD. And MRD is, again, looking for 1 myeloma cell in 1 million or 10 million normal cells inside the bone marrow. And that's a measurement of taking that ice cube and shrinking it down to just a sliver of ice that you can barely see and only need advanced technology to pick up on. And we call that the IMWG response criteria. The other thing that we talk about in clinical trials is overall survival. So how long does somebody live from the time they entered the trial to the time they died of myeloma or something else? Progression-free survival. You really want to know, if you're on a therapy, how long would that therapy last? So that's progression-free survival. We'll talk a lot about how long do these therapies last. And then the side effects, the adverse events. And so there'll be a lot of AEs or treatment emergent adverse events. So you want to know the side effects of the drugs that you're getting on, because these drugs do have side effects. And then the big thing used to drive me bananazoid is that when I started looking, when I went to conferences, people would put up these curves, and I'm like, what do those curves mean? Everyone's all excited about these Kaplan-Meier curves. And it's kind of straightforward, that it's a way to be able to tell one therapy versus another therapy. And when you're on a treatment and nothing bad happens, so you're not relapsing, the curve stays flat. But if patients are relapsing, the curve goes down and down and down. So it's a graph that can tell us one thing versus another. And the steeper the curve, the worse things are. The more events, the more people are relapsing. The flatter the curve means less events and patients are staying on a treatment longer, which tells us that it's working better. Does that make sense, I hope? Because I have these curves in there, but I think to really get the impact of what these drugs can do, it's important to know how these curves work. And then the last thing about where clinical trials are. So they're phase 1 clinical trials, and that's when you give a drug to a cancer patient for the first time. They've never seen this drug before. No one has seen this drug before. And what you're trying to figure out is, what are the side effects in cancer patients with a drug, but what is the recommended phase 2 dose? You want to know what dose you give people. So a phase 1 trial, you increase the dose real slowly, and then you find the correct dose. You find the recommended phase 2, the RP2D. I got my R2D2 socks on. We're talking about the RP2D. Gosh, it's hard to say in combination. The phase 2, you get that dose from the phase 1. Then you found the right dose, you give it to a bunch of people to see how well does it work, and should you move on to the phase 3. And the phase 3 is the most important because you get the current standard of care, the thing that we like the most right now, and you're putting that new therapy up against it. Because what you're hoping for is that new therapy will beat the standard of care, make it the old standard of care, and that has then progressed, and now you have a new standard of care, a new treatment for people. The regulatory agencies look at that phase 3 trial, they say, yep, better than what we have now, we're going to approve it, and then phase 4 is when you see if there's any side effects after it gets approval. One thing that can happen is that you can get an accelerated approval. If your drug appears to knock it out of the park, or if it meets an unmet need, it can be approved in the phase 1 or phase 2 setting, but it has to prove itself in phase 3 in order to keep that approval. And Joe showed a bit of this slide before. These are the targets. So all the therapies we're going to talk about that are new on the horizon target the myeloma cell. Myeloma cells have a specific license plate that tells your body, I'm a myeloma cell. One of those is something called SLAM7. We have elotuzumab, an antibody against that, and antibodies destroy anything that's attached to an antibody will be destroyed by your immune system. That's how your immune system clears out things. GPRC5 is another protein on myeloma cells and on skin cells, and there's a bispecific we'll talk about called lacutamab, and there are CAR-Ts in development for that. FcRH5 is another protein on myeloma cells that can help target the myeloma cells so you can get to them. And then everybody loves CD38 because that's where your daratumumab, that's the Dara or the Darzalex, that's what it targets. And then BCMA has exploded. Everybody loves BCMA because there are lots of different immune therapies. And BCMA is very specific to myeloma cells. It can pick those cells out of all the other billions of cells in your body based on BCMA. So we've used that a lot to target myeloma cells. So we'll start with the antibody drug conjugates, the belantamab. So just like Joe said, it's an antibody, but it has 2 chemotherapy agents attached to it via a linker. And so it's carrying, just like Joe said, a backpack of toxin with it. And it can find, instead of giving you that toxin, letting it run all through your body, this will deliver the toxin directly to the myeloma cell via BCMA. So it attaches onto the myeloma cell through BCMA, and then it gets integrated inside the cell. I can't tell you how long it took me to get that little antibody to wiggle through that cell. And every time I hit that button, I'm like, please wiggle. So it did it. So I can just say goodnight. Once it's inside the cell, then it unloads the toxic payload only to the myeloma cell and kills it. But not only does it do that, but it gets the immune system cells, those T cells and those other white blood cells, to attack the myeloma. So it's a 1-2 punch that this drug uses to kill myeloma cells. Oh, that's easy. I got some other animation I'm praying will work. Yeah, the little explosion, no problem. So belantamab was approved, actually conditionally, accelerated approval, based on a study called DREAM-1, where they gave it to patients that had more than 5 lines of therapy. And this, a few years ago, this was remarkable. I thought 66%, and usually the response rate is 30, 20%. That was off the charts. But everyone had side effects with it. And the big side effect were eye problems. That this toxin that should be delivered to the myeloma cell got into the lens of the eye and would cause little dents into the cornea, which would cause people to have blurry vision. So people had to get eye exams before they ever got dosed with this drug. What happened is that it ended up, when its phase 3 trial, it lost its phase 3 trial, was pulled, and then they came up with 2 other trials, DREAM-7 and DREAM-8, where they randomized, they made, instead of giving Blenrep alone, they gave in combination. One combination was with Velcade and dexamethasone versus the standard of care, which was daratumumab, Velcade, and dexamethasone. And DREAM-8 was when they got Blenrep along with pomalidomide versus pomalidomide or Pomalyst and Velcade alone. So standard of care versus new therapy. And when you look at DREAM7, which was the Blenrep plus Velcade versus Dara plus Velcade, you can see in the blue line that the Blenrep arm did better. That more people stayed on therapy. The line was flatter. Therefore, that was superior to the daratumumab Velcade. And you look at how long people remained on therapy, how long did this stuff work? It was 36 months versus 13 months. So superior outcome for DREAM7. Most importantly is that people lived longer. That was a big selling point for this combination. That when you looked at people who got Dara Velcade versus Dara Blenrep, people lived longer. And the response rates, if you look real closely, the overall response rate, the ORR wasn't all that different, but there were more deeper responses with the Blenrep because it was targeting that BCMA in earlier lines of therapy. And again, duration of response, much, much longer for the Blenrep arm. DREAM8, remember, was a study that was Blenrep, Pomalyst, and dexamethasone versus pomalidomide, Pomalyst, and Velcade, and dexamethasone. And again, you can see happier, that people did better. And that line is super flat when you get to the arm that had Blenrep, Pomalyst, and dexamethasone. Again, at 12 months, there were more people that were still on treatment because it was working than there were on the pomalidomide Velcade on Dex arm. And again, NR means not reach. That so many people remained on treatment because it was still working, that's not reach, as opposed to only people were on the other therapy only a year. And again, response rates are similar, but more deeper responses. Again, you shrink that iceberg down to a little ice cube, it's going to take longer for it to grow back. So better, deeper responses, and it lasts longer. And so if we look at side effects between the two, basically a lot of those side effects are eye side effects. So lots of patients had blurry vision. A lot of my patients said that their vision was blurry for a couple days and then it got better. And some patients, we actually would hold therapy, and we would hold therapy for 8, 10. So I had one patient hold it for a year because she's like, my myeloma is under control. Why you keep dosing me? I'm like, I don't know. And so she stayed off therapy for a year, and this drug, for some reason, kept working. And I think that's one of the best things about this drug, is that you can hold it for long periods of time and the myeloma won't come back. We think it's because the drug causes your immune system to finally recognize the myeloma and destroy it. Because of the eye symptoms, patients always get eye exams, and then there's a reaction that we take. If people are having problems, we'd hold the drug, sometimes lower the dose, but we have a action plan if there are eye symptoms, which keeps people to maintain their vision. And again, it had some of the other side effects, but not as much as some of the other drugs I'm going to talk about, like low platelets. And there were some increased infections, so we have to watch for that too. So that is, and that drug was not approved, reapproved in the United States by the ODAC, is like the pre-FDA hearing. I was at that, Ginny was at that. Man, that was something. I'm still talking to my therapist about that. But it sounds like it was approved in Canada. So that's good news. Now I think it has to be approved by some of the regulatory agencies regarding cost. So now let's talk about CAR T. So there are the B cells, they help fight infection. Then there are the T cells, and they help fight invaders and misbehaving cells and mutated cells. So we'll talk about CAR T. Get it? Model T car. I'm from Detroit. I think that's funny. Here's what I really think is funny. I think Mr. T in a car is the funniest thing. Mr. T and I have traveled the world. I think I look at that slide and I laugh because I just love Mr. T in a car. Mr. T had T-cell lymphoma, by the way. He's doing fine. This is what CAR T is. CAR T is a T-cell killing a cancer cell. So here's a little cartoon, or actually a electron micrograph movie of a T cell killing a cancer cell. So there's the T cell, there's the cancer cell, and a T cell just hits it and unloads its toxic payload inside the cancer cell. Does it over and over and over again until the cancer cell just finally dies. So it's a little bit slow. And then the T cell goes to see the T cell kills the cancer cell, and it goes about its way. It's looking for more cancer cells. That's the power of the T cell, is that it will kill cancer cells, and it can find them specifically. The reason that people get cancer is that their cancer has found a way to evade the T cell. If I don't want to get caught by, I shouldn't say that. Never mind. I was going to talk about cops and me when I was young, but that was the younger version of me. And now I am a dad, I'm bald, and I just play by the rules. I'm cool. Okay, carry on. Don't tell the border people I said that. So here are the cancer cells in mauve, I think, and the T cells killing them in teal. And how do those T cells find the cancer cell? Is that those T cells find the cancer cell by a cancer antigen, a little sign on the cancer cells that says, I'm cancer. So how can we get your T cells to find your cancer cell? Well, we can actually get that by using a chimeric antigen receptor. So we can reprogram the T cells to finally recognize your cancer cell and start to hit it like we did in that cartoon. So we get your T cells and we harvest them just like we harvest stem cells for a transplant, except this time we get those T cells and we get a virus. That virus has got all the bad stuff taken out of it, and the only thing it has is a gene that helps recognize cancer cells. You then get your T cells. That virus will infect the T cells and place that gene, this is called genetic programming, inside the T cell. The T cell is like, new information. It reads that gene, and then it starts to produce an antigen receptor for cancer when it hadn't done that before. So it reads the gene, and now that T cell has no choice but to kill cancer cells. You grow billions of them in culture, then you give that back to the patient. And so to make it a bit easier, that it is, again, just like Joe said about, the soldier, the Rambo T cell, that you get a pretty just casual T cell infected with this virus that just has a programming to kill cancer cells. And now that T cell is angry. It is, can I say pissed off? Pissed off. And it is finally able to recognize the cancer cell. So again, in myeloma, BCMA is the target, and we get just plain old T cells from your body, and then we transfect them to have them express receptors for myeloma cells. And then we grow those in culture. It takes about 2 weeks to do that. And then we give it to the patient, and they start hunting cancer immediately. The best thing is that they start to reproduce in your body. Those T cells are like, I'm back home. So now those cancer-fighting T cells are producing more and more cancer-fighting T cells. So you have an ongoing therapy. You don't have to go to the doctor's office again. You have an ongoing therapy that's constantly there surveying for cancer, even if you're in a remission. And so, again, we've reprogrammed T cells and to find and hunt down cancer cells. And there's a POW. I should make that a bit larger. More dramatic. Are there toxicities? Yes. Because when you have all those T cells all of a sudden hunting cancer cells, you can have something called cytokine release. Cytokines are chemicals that give you fever, that give you chills, that give you shortness of breath. Like when you have a virus or a cold, you have a little tiny bit. But when you have these T cells suddenly hunting cancer cells, you can have what we can call grade 1, very mild cytokine release, or grade 4, where it's severe and you have to be in the ICU. Also, there's some neurotoxicities that accompany it, where you can have word finding difficulty writing. Again, it's not because of the cancer, it's because the T cells are killing at a rapid rate. And you'll see this with other T-cell therapies, I'm always looking to see, is my patient having a little bit of that? Because it's helping me understand that the T-cells are finding the cancer cell. And we have, after years of giving CAR T and bispecifics and T-cell redirecting therapy, we now know how to treat it and how to prevent it, the CRS and the ICANS. And so I'll show you that the vast majority are pretty low grade. So there are two approved CAR T therapies. I'm going to have a discussion with the people from cell to cell. I meet with them, and I'm going to give them a piece of my mind about them not having that approved here, because I was annoyed. I mean, I could go on days. I mean, my other hat is health equity. I have no tolerance for, don't say that, Craig. I have no tolerance for this BS about not having drugs accessible to everyone when it has efficacy like that. So you can see how I got in trouble when I was younger. I gave people a piece of my mind. And they're like, oh, you shouldn't do that. So now I'm grown up, and I'm okay. So a little bit, what can these cells, what can these CAR T cells do? Here's a patient, here's a PET scan. Now the normal part of this PET scan, the brain always lights up on a PET scan, the kidneys always light up, and the bladder always lights up. So you can see there's a lot of myeloma. The other black spots outside the brain and the kidneys and bladder are all lighting up with cancer before the CAR T. After CAR T, poof, gone. And so that is a power of having T cells, living cells, kill your cancer cells. And so again, the way that CARtitude 1, which was one of the first clinical trials with this particular agent worked, and this is how it works today, is that you make sure that the patient is eligible for CAR T. You use some type of therapy, because remember, it takes about 10 weeks to manufacture the CAR T. So they need some type of bridging therapy to keep their myeloma under control, at least until they can get the CAR T. Then you give lymphodepletion. You give 3 or 4 doses of chemotherapy to wipe the slate clean of any other T cells that will fight the CAR T cells, and then you give the CAR T on day 1. And then you watch for those symptoms. So at our hospital, we watch people for about 6 to 8 weeks. We watch them. They're not in the hospital the whole time. They're in the hospital maybe about 5 or 6 days. We also do outpatient CAR T when people live close by. And then we're monitoring them for the ICANS and the cytokine release syndrome. And then we do post-assessment, because remember, this kills all myeloma cells, kills all plasma cells. We have to watch out for infection. So we're watching out for infection and have people on antibiotics. But you can see with the CARtitude 1 CAR T, the response rates are 97.9%. Duration of response, is for really sick patients. These folks had failed multiple lines of therapy. The usual response rate, again, is like 20 to 30%. To hit 90% is amazing. And you can see, just like the slide that Joe had about it, that line is super flat, that there were no more relapses and events for a third of patients, even at long term. So people started to talk about, is this curative therapy? And that is, we have to come up with a definition of that first. You can see that with CRS, most patients have some type of cytokine release syndrome. Most of them were low grade, only lasted a few days. But things like having infections is a big thing in the long term you have to watch out for. And this was in the New York Times about potential cure for blood cancer based on the study. And I would say that this is this particular product a cure for myeloma. I think the concept of using T cells to fight cancer is a curative option. And I think that we need, and I'll talk a little bit about how we're exploring this, because the problem with CAR T, it is, even in the United States where it is FDA approved, the vast majority of patients don't have access to CAR T. About 5 to 6% have access to it. The vast majority of patients don't have access to that. I say it's not a cure until everybody has access to it. And don't even, you can think about that word, but the cure is only if everybody has access to a particular regimen. Cartitude 4 is when they're giving in earlier lines of therapy. It went up against the standard of care. Again, super high response rates. And I could go on and on about how great these response rates are for CAR T, but now we're using it further and further up front. Again, high side effects. So you have to be very careful in using these drugs, including hypogammaglobulinemia. What in the world is that? It's a Jeopardy answer. If you watch Jeopardy like I do, I'm waiting. Actually, it's not. I'm waiting for that answer or that question to come up. It hasn't yet, but that means that you have no antibodies because the CAR T has destroyed the normal plasma cells. So patients usually need monthly infusions of normal antibodies to help boost their immune systems up to prevent them from having an infection. So it's 33% of patients that were off therapy with Cartitude 4, were they ever seeing their doctor? They were probably seeing their doctor once a month, getting immune boosters and checking for infection, because that's one of the long-term risks of having CAR T. And now we're moving it really up front, is that Cartitude 5 and 6, which I think have already enrolled and filled, are looking at giving it in frontline therapy. So hopefully next year, we'll be talking about the results of these trials. But again, very exciting. There are now dual CAR Ts. So instead of just having having the CAR T look for one cancer cell antigen, now there are two. One is CD19, which is on baby myeloma cells. So with this CAR T product, you're hitting the mature myeloma cells and the baby ones at the same time. And it's produced way faster than the old CAR Ts, which again, old CAR T, with the current CAR T products, which takes again about 8 weeks to manufacture. But even though they're a small number, because it's a phase 1 trial, you see 100% response rates. I mean, I'm still shocked by the reason I went into hematology is I saw that some cancers had 100% response rate. And I was like, that will one day happen to myeloma. And now that is really becoming the new standard, these very, very high response rates. There's a study in newly diagnosed myeloma using the dual CAR T, and look at that. Everybody had 100% response rate, and it's all blue, which means they're all deep, deep responses. Is this drug going to be accessible to everybody? No. Is the concept of using T cells to kill cancer cells, do I think that'll be available to everybody? I really think that will, because what I don't have a slide for is in vivo CAR T. So instead of taking your T cells, instead of go to some fancy place to have your T cells taken out, you send it to a place, transfect them with a virus, and then putting it back into you. Why don't I just give you the virus? Why don't I just give you the program virus and have it infect your T cells in your body so you start killing the cancer right away? And that's what in vivo CAR T, they're really early. They're so early I can't show you any slides on it yet. But that, I think, because that can be off the shelf, you don't have to go to a specialized center to have it done. You just thaw the cells out, thaw the virus out, infect somebody, it then changes your T cells to kill your cancer. That is remarkable, in my opinion, and could be widely accessible, I hope. Make sense, I hope? Oh, I'm not done! I'm not done yet. Uh-oh. Okay, I'm sorry. I didn't mean to scare you guys. So bispecific antibodies. So usually all our antibodies are monospecific. They're out to kill only one type of whatever. You can build antibodies against anything. So we built daratumumab against CD38 on myeloma cells. You can make an antibody against a T cell, which is, and a protein on T cells is CD3. and you can make a protein against BCMA. You can join those two together to make a bispecific antibody. I hope this works. And then that will then attach to the one arm will attach to the myeloma cell, the other arm will attach to the T cell, and just like in that movie, the T cell unloads and starts punching the myeloma cell. I can't tell you how long it took me to get the little Pac-Man guys. I mean, that was, and I just had it in my brain. I couldn't give it. I was like, I want the damn Pac-Man to work. So Pac-Man works, and I think, big explosion. But that is, instead of going and having your T cells transfected to have the T cells find the myeloma cell, this just pulls it right together immediately, right off the shelf. And there are lots of different bispecific products, and I'll kind of go through them. The first one out was teclistamab. It's against BCMA that we know about. It's given usually once a week after it has a couple step-up doses we'll talk about in a second. They gave it to patients that had 5 lines of therapy. Response rate is about 60%. Duration of response is super good. Again, the standard is 30%, so 60% is double that. Infections, we had to watch out for infections. LRAN came out second, looks a lot like teclistamab, a lot of the same response rates and everything. So it used to be called AbbVie 383. That was called Intentamig, and they broke the MAB thing, which is driving me crazy, but I shall adapt. And the one thing about that drug is that it has a double BCMA, so it's super sticky to myeloma cells, but the T cell end is weakened a bit. So it's super sticky. The T cell jumps on the myeloma cell, punches it, moves on, and then the next one jumps on it. So you don't have so it can be given over over an extended period. So it's given now every 4 weeks, and pretty similar response rates, but that's still in clinical trials. Linvo is just approved in the United States, another BCMA, maybe a little bit more efficacious, but I think they're all the BCMA ones are pretty standard and pretty equal. Lacutamab is against GPRC5, a different protein on myeloma cells and on skin cells, so we'll talk about that. And cevostamab is against FCHR5, and that's still in clinical trials. But there's step-up dosing to all these things. If I gave you the full antibody, you would have super bad cytokine release syndrome and feel sick and would actually get really sick. So we give you a tiny dose of these medications, get the T cells kind of acclimated and get them a little bit angry. Then we wait a few days, give you a bit of a bigger dose, have them start to get more active, and then give you a larger dose. Sometimes that happens in the hospital, where patients have to stay in the hospital for 7 days, but now we're moving to more outpatient dosing, a separate dosing of the bispecific antibodies. And pioneered here in Toronto was using tocilizumab. So TOSI is the antidote to cytokine release syndrome. Why don't we give you that before? And we try to do that before. It's actually the National Comprehensive Cancer Network guidelines does recommend giving this before in certain patients that are high risk of having CRS. And it reduces it down from 70% down to 20%. It does a good job. GPRC5, the talquetamab, is also found on skin cells. And so skin in your mouth, skin in your eyes, skin on your hands. And so it attacks the myeloma cell, which has GPRC5, but also attacks the skin cell. So the reason this person's skin is peeling is because the T cells are after them too. And so people will lose their sense of taste. They will usually lose weight and have their fingernails, but a lot of these are manageable with dosing and dosing changes, but one thing to kind of watch out for. But using talquetamab in combination has really been remarkable. That when this drug, in 2 different trials, it was used with pomalidomide and daratumumab, where you got the talquetamab, you got the teclistamab, first, and then you got the dara and pom. And when you look at these response rates, again, 94% response rate in patients that have had 1 to 3 prior lines of therapy, and 70% response rate. So, but in combination, these drugs actually worked a bit better. And then adding teclistamab and talquetamab together, what if you combine the two bispecific antibodies and give it as a combo pack? Again, 70% response rate in patients that have had lots of prior therapies. And I think some of the hardest myeloma, some of the most difficult myeloma to treat is when it's extramedullary, which means it's not attached to any bone, and it's just masses in the lung or in the skin. And response rates are usually more like 10 to 20%. Again, 50% response rate. So at Karmanos, when we see an extramedullary patient that's relapsed, we usually give them the combo pack of teclistamab and talquetamab. Again, it has side effects, but the good thing is that the side effects aren't additive. They actually run parallel to each other. So the toxicities aren't exacerbated by combining the two drugs, but you will have the side effects of each drug independently. And really kind of where the field is going is the tri-specific antibodies. So why can't I make if I can make an antibody towards T cells and BCMA, why can't I make an antibody to T cells, BCMA, and GPRC5, which really gets those T cells to find the myeloma cell? If the myeloma cell says, well, I think I'm not going to make BCMA, see if I can escape those T cells, then it still has GPRC5, and the drug will still find them. So having three proteins going after the myeloma cell is it better than just having two? And in the phase 1 trial, they were looking to see what's the best dose. So they're looking for that recommended phase 2 dosing. So they said, what's the best dose? What's the best dose escalation? What's the best interval? And they found that giving a tiny step-up dose of 5 milligrams, followed by just one step-up dose, and then 100 milligrams every 4 weeks, very easy for patients to come in once a month for therapy, is better than a lot of those other ones you come in once a week for. And you look at these response rates, again, ridiculous. 100% response rate. Super small trial, so super small. But again, for patients, this is remarkable how well these combinations of drugs work, especially at the going forward dose. And their clinical trials are ongoing with the tri-specific antibody. And the side effects, again, pretty standard side effects you see with the drugs independently. With the bispecific antibody, adding another arm didn't really increase any of the toxicity. When you look at the patients that are on it, so this is called a swimmer's plot, and you see all the arrows mean all those patients that were getting the recommended phase 2 dose are still on therapy, except for one person that died of a pneumonia. But everybody else, is still on therapy. And you see how flat that top red line is because no one's relapsing after 12 months. And so incredibly effective therapy, very excited about it. And so the big question we always have, and we actually, on an individual patient basis, this is what I do basically day in and day out when I'm in clinic, is we want to do a bispecific or do we want to do a CAR T? The good thing about the bispecific, I can give it to you right away. I mean, I think at our institution, it's got to be about 3 days for me to get approval for a bispecific. CAR T is going to take a bit longer to get approval for. Both have very deep responses. I think I showed you that. And I'd say the bispecifics do have a little bit less cytokine release syndrome than the CAR T does. It doesn't require as much hospitalization. I mean, like we do our bispecifics mainly as an outpatient. The problem with the CAR T is it takes so long to make. That's going to be fixed. The bispecifics are continuous therapy. That's a pain in the butt. But we now have clinical trials that have built-in discontinuation. So it's not going to be that way for forever with the bispecifics. If we have a very good response, we're now getting confident to discontinue therapy. We're moving to actually monthly dosing for the bispecifics, but still CAR T is one and done. You really can't beat that. That you get one therapy, you're in the hospital for a bit, then you're not on ongoing therapy because the therapy's ongoing in you're making the new cells. And there's a cost difference. that CAR-T is, very expensive. Bispecifics not as expensive. And we need to fix that. I think that needs to be one of our primary jobs, is to find that. And I'll be honest, at our institution, thank goodness we have the option for different bispecifics. We told them, I'll tell them today or tomorrow. I'm like, you make your drug cheap, I'll be more than happy to use it. They're all equal. I showed you that all the ones are equal. I don't care, because they're all equal, but you need to lower the cost of your drugs so more of my patients can get those drugs. And so where do all these therapies come from? We started out, the standard of care when I had hair. I had a high top fade back in the day, and I thought I was cool. But and the standard of care was chemotherapy. Was giving melphalan and prednisone, or vincristine, adriamycin, dexamethasone, and lots of side effects, little efficacy. But then there was a clinical trial that included Revlimid and dexamethasone. It became the standard of care. So then we did we said, that's way better than chemo. What if we add on to that? So we did Velcade, or Revlimid, dexamethasone versus Revlimid, Velcade, and dexamethasone. That clinical trial became the standard of care. And now we are moving up where we're having less side effects. I'm talking about CAR-T therapies, and I'm talking about bispecifics and trispecific therapies that have less side effects, but they're way more effective, which inevitably would lead us to a cure. I'm very confident about that. But the people walking up the steps are patients, because they're being involved in those clinical trials. And is it scientists, is it doctors, is it nurses that are pushing the needle forward? We help. But it's patients being involved in clinical trials that are making all this possible. And that's why my biggest honor is to talk in front of patients, because I'm indebted to your grace to be able to have me put up numbers that say 100%. And I thank you for that.